Доброго дня, шановні колеги. Ви
Hello, dear
підключаєтеся до
colleagues.
вебінару
You are now joining a webinar organized by the Ukrainian Public Health Center together with the colleagues responding to multidrug-resistant microorganisms, contact precautions, and also isolation precautions. I suggest we give another minute to make sure that all the participants have a chance to join us, and then we make a good start.
Отож, я бачу, що кількість слухачів
So,
вже
colleagues, I
більше.
can see that the number of our participants is rather stable. We can see some new participants join in. And our today's lecture is a continuation of a cycle of lectures dedicated to the European experience of implementing IPC measures, perspective for Ukraine. These lectures is something that we have had in a certain period of time, being conducted with our colleagues from MyCap, University of Columbia, and colleagues from AskMed. The speakers are usually rather experienced colleagues from AskMe community. During our lectures, we have a simultaneous translation option available in Ukrainian. In order to listen to that in Ukrainian, please go to the Zoom settings, and on the basic panel below, you go to a globe-shaped button, and then select the Ukrainian channel for your convenience. And here on the slide, you can see some instructions how you can set your translation option. After our today's session, that will take about 1 hour, you will have a chance to ask your questions using the chat box if you have any to our today's speaker. I would like to remind you, colleagues, that just recently during the series, it was implemented that during the series of these lectures, you can get your continuous professional development score. In order to get your continuous professional development score, you need to be registered on the educational platform of UPHC for this given lecture. The reference link for registration was available in the announcement for our today's webinar. That was available on the Facebook channel of UPHC. In order not to skip the announcements of such webinars and seminars, and more specifically those for which you will be provided with a CPD score, please visit our Facebook channel, follow it, and you will always have a chance to get back there to get your CPD score. It is required that you go on your account on the educational platform, and then once you get registered for the course, you need to take the testing. And the testing will be open until the end of the day tomorrow. So please do not miss this opportunity and take the test. The threshold is 80%. The pass threshold is 80%, and in order to avoid unattentive listening to the lecture, we're going to use a keyword during the lecture, and we will specifically focus on that word. So please memorize it and listen to today's educational material carefully. So I suggest now we switch to the lecture, and the topic of our today's lecture is responding to multi-drug-resistant organisms. We will speak about the IPC measures, cleaning, isolation, and the speaker is a very well experienced professor, Emine Mese, professor, PhD, professor of the Faculty of Infectious Diseases and Clinical Microbiology, Medical Department, University named after Yıldırım Beyazıt in Ankara, and she will be the one speaking about our today's topic. So I will not waste any more of your time, and let's get to the lecture. Over to you, Professor, please.
Thank you so much for this nice presentation. And yeah, Good afternoon, everyone. Today I will talk about something that sits at the intersection of everything we do in hospital medicine, responding to multidrug-resistant organisms. This is not a niche topic. It is one of the defining challenges of modern healthcare and how we respond to it, both individually and institutionally. I'm sorry, I cannot. I cannot go my slides from here, but I will try it. So I can go on from here, maybe, yeah. By the end of this session, you should be able to understand the epidemiology of multidrug-resistant organisms, recognize the transmission of major transmission routes by which these organisms spread within healthcare settings, and apply evidence-based prevention and control strategies for MDR microorganisms, and finally understand how to implement IPC, infection prevention and control strategies in a practical multimodal framework. Before we go further, let us define our terms clearly. MDR. MDR is multidrug resistance, refers to resistance to 3 or more antimicrobial classes for organisms like Pseudomonas aeruginosa and Acinetobacter baumannii, and this is the three shots for all these microorganisms. For MRSA, resistance to even one key antimicrobial agent qualifies it. Beyond MDR, we have XDR, extensively drug-resistant pathogens, which means resistance to nearly all approved agents, leaving clinicians with very few options. And at the extreme end, pan-drug resistant. Pan-drug resistant means the organism is resistant to all commercially available antimicrobials, routinely tested, and these are infections for which we may have no effective treatment at all. This classification is from the CMI, and it's ASCMID classification. And beyond the laboratory definition, there is a more clinically useful framework from Dutch colleagues in 2025. They define an MDR microorganism by 3 key characteristics. First of all, the microorganism must actually cause disease. It's not merely a colonizer. Second, it has acute antimicrobial resistance that hampers empirical therapy, meaning our first-line treatment choices may fail. And third, and critically for us as infection control practitioners, it has the potential to spread if transmission-based precautions are not implemented. This third point is the reason we are all here. These organisms are not just a treatment problem, they are a containment problem, and containment is largely within our control. And the next slide. Why should we care so deeply about MDR microorganisms? The consequences are stark. MDR microorganisms drive higher mortality. Patients infected with resistant organisms die at the at significant higher rates than those with susceptible strains. Treatment options are severely limited. When first, second, and third line antibiotics all fail, we are left with agents that may be more toxic, less effective, or simply unavailable. And hospital stays are longer. Patients with MDR infections require extended admissions, more intensive nursing care, and prolonged isolation. And the costs to health systems, to patients, and to society are dramatically higher. And this is not a theoretical concern. These consequences are playing out in hospitals around the world every day, every single day. Let us now turn to the epidemiology of antimicrobial resistance, the big picture of where we stand globally. The World Health Organization has designated antimicrobial resistance as one of the 10 top global health threats of our time. It currently causes an estimated 700,000 deaths per year globally. But if we fail to act, projections suggest this number could reach 10 million deaths annually by 2050, more than cancer kills today. The question is no longer whether AMR is a crisis, it is whether we will respond in time. And for the next slide, the economical consequences are equally staggering. Inaction on AMR is projected to cost the economy $100 trillion cumulatively, exceeding the entire current global GDP. The 10th front strategy outlined in the review on antimicrobial resistance chart provides a roadmap, mandate rapid diagnostics, launch public awareness campaigns, establish innovation funds, and implement market entry rewards for new antibiotics. Then in the next slide, there's a graph. This is from the WHO Global Antimicrobial Resistance and Use Surveillance System, GLASS. 2025 reports reveals a striking pattern. Countries with less antimicrobial surveillance coverage tend to have higher rates of antimicrobial resistance. And look at the graph, you can see that African and Eastern Mediterranean regions, high rates, resistant rates, low surveillance coverage. And the European region clusters at the lower end of resistance, you can see in the graph, with higher coverage. This is not coincidental. Surveillance identifies the problem without knowing where resistance is occurring and which organisms are spreading. We cannot mount an effective response. This underscores the importance of investing in diagnostic infrastructure globally. And in the next slide, this figure from the GLASS 2025 report shows median nation resistant rates in bloodstream infections plotted against universal health coverage index scores. The pattern is clear. Low income and lower middle income countries shown in red and orange have dramatically high rates of antimicrobial resistance. And this tells us that AMR is not just a microbiological problem, it is a health equity problem. Countries without reliable access to effective antibiotics, clean water, infection control, infrastructure, and diagnostic laboratories bear the heaviest burden. This addressing MR requires the underlying disparities in global health systems. And you can see the detailed resistant rates of microorganisms in this graph. This map also illustrates the projected distribution of AMR attributable deaths across world regions. Asia bears the greatest absolute burden. Africa follows it, and these numbers are staggering. Europe and North America are not spared also from the deaths. But when you look at mortality per 10,000 population, the disproportion in low resource settings becomes even clearer. And this slide, from the next slide, this slide needs a little explanation, but it deserves a moment of reflection. Former UK Prime Minister David Cameron warned, we are looking at an almost unthinkable scenario where antibiotics no longer work, and we are cast back into the dark age of medicine. This is not hyperbole. Routine cesarean sections, cancer chemotherapy, organ transplants, and joint replacements, all of these depends on effective antibiotics. And without them, modern medicine, as we know, it would not be possible. So, in 2015, the WHO launched the Global Action Plan on Antimicrobial Resistance, and the plan defined 5 strategic objectives. These are improve awareness and knowledge, prevent infection, optimize use, secure sustainable investment, strengthen surveillance and research, and build global governance. Not that we understand why MDRs matter and how widespread they are. Let us examine how they spread, the mechanisms of transmission that allow resistant organisms to move from patient to patient, from environment to patient, and across health systems. Here in this diagram illustrates the key pathways by which hospital-acquired infections occur. The center figure is the patient in bed. Infections reach them through 2 main routes: direct infection from contaminated medical staff or visitors who have touched the patient or their environment, and indirect infection mediated through contaminated medical equipment, devices, implants, and hospital facilities such as sinks, toilets. Healthcare workers are at the center of this transmission network. Their hands, clothing, equipment can carry organisms from one patient to another, from the environment to the patient and back again. Understanding these pathways is essential because it tells us where to intervene. Every link in this chain is a potential point of control. In this slide, there's a classical epidemiological model of infection. The chain of infection identifies 6 links: the infectious agent, reservoir, portal of exit, mode of transmission, portal of entry, and susceptible host. For MDR microorganisms, susceptible hosts include not just the elderly or immunocompromised patients, they include anyone in the hospital, anyone admitted to a healthcare facility is potentially at risk. Reservoirs include people, colonized patients, carriers among staff, as well as animals, soil, food, etc. Portals of exit and entry include the mouth, nose, eyes, and cracks in skin. And the key message here, it is highlighted clearly on this slide, is that IPC measures break this chain. Every element of our infection prevention program targets one or more links in this chain, and remove a link, and transmission is interrupted. Here is data from my own institution, along with study published in anaerobe in 2011. Now extended to with ICU surveillance reports through 2023. On the left, you can see infection rates by type and nosocomial pneumonia and bloodstream infection were the most common healthcare-associated infection, both from 2000 to 2009. And bloodstream infection were the most common pathogens also in the next decade. And this slide shows the distributions of pathogens in our ICU over the same time periods. In both periods, gram-negative pathogens, Acinetobacter baumannii, Pseudomonas aeruginosa, were most common pathogens. Knowing your local epidemiology is not optional, it is foundational to effective MDR management. And here in this slide, you can see the resistant rates of these pathogens. The patterns are striking. From 2000 to 2009, resistance to most agents, including carbapenems, was variable but present. From 2014 to 2023, the picture is grimmer. Resistance to meropenem and ciprofloxacin approached or reached 100% in recent years. And amikacin resistance is also very high. And the green bars represent colistin, our last resort. Here you can see resistance there remains lower, but it is not zero. We are running out of reliable options. So this is exactly why antimicrobial stewardship cannot be separated from infection prevention. Then the two go hand in hand. Here, this slide is from our study, one of the study we published in Scandinavian Journal of Infectious Disease in 2006, one of our early investigations into the epidemiology of Acinetobacter baumannii bloodstream infections. The highlighted message on this slide captures the most important finding from the genotyping analysis. Nearly 80% of ISOs belong to just 3 genotypes. That suggests cross-transmission in ICU settings where infection control practice were poor. And also in another study, we examined Acinetobacter baumannii colonization and infection in a medical intensive care unit, ICU, in intubated patients, and we found that 45% of these patients were colonized with Acinetobacter baumannii at the end of this first week, and among these colonized patients, 80% developed infection. And also, what are the risk factors? We identified the key risk factors for developing Acinetobacter baumannii infection. And you can see that length of intubation was a significant independent risk factor for and each additional day on the ventilator increases infection risk, and diabetes mellitus was associated with a 4-fold increase in risk. Acinetobacter baumannii colonization itself, as I mentioned, was an independent risk factor, and also tracheostomy was associated with nearly a 5-fold increase in risk. What does this tell us clinically? Patients who are intubated, diabetic, or who have a tracheostomy warrant heightened surveillance and more aggressive infection control measures. And risk stratification should guide the intensity of our prevention efforts. Also with genotype, these pathogens, and we showed that 88% of the isolates belong to clone A, only one clone. And this also suggests the cross-transmission. This diagram elegantly summarizes the cycle of cross-transmission in the ICU. It begins with colonization. Microorganisms, particularly Acinetobacter calcaticus, present on patient's skin or in the immediate environment. Step 2, transfer. Microorganisms move to healthcare worker hands or gloves during routine clean procedures, taking a pulse, measuring blood pressure, and you do not need an invasive procedure to become a vector. Step 3, survival. Gram-negative bacteria survive on skin for hours, and artificial nails and jewelry triple carriage risk and harbor colonies that are resistant even to alcohol hand drops. Step 4, inadequate cleaning without proper hand hygiene. Microbial counts on hands increase linearly with time. And step 5, transmission. Up to 53% of ICU contacts result in cross-transmission to a new patient, and break any of these links here, and particularly hand hygiene, and you interrupt the entire cycle. And with this understanding of how MDR microorganisms spread, let us now turn to what we can do about it, the evidence-based strategies for prevention and control. The WHO guidelines for carbapenem-resistant pathogens provide a clear framework for what an effective infection prevention control program must include. These are the core elements: implementation of multimodal IPC strategies, hand hygiene, surveillance, contact precautions, patient isolation, environment cleaning, environment surveillance, cultures, and monitoring, auditing, and feedback. However, no single measure alone is sufficient. The evidence constantly shows that these strategies must be implemented together as a bundle to be effective. Each element reinforces the others. So today I will talk through each of these components. Effective MDR organism control requires at minimum 5 core elements: hand hygiene, patient isolation and contact precautions, active screening cultures, environmental cleaning, and antimicrobial stewardship. The integrated approach, implementing all these elements simultaneously and in a coordinated fashion, is considered the most effective way to successfully implement IPC interventions. Why does integration matter? Because MDR pathogens exploit every gap. So if you improve hand hygiene but neglect environmental cleaning, organisms persist on surfaces and recontaminate hands within minutes. If you isolate patients but fail to screen for asymptomatic carriers, hidden reservoirs continue to seed the unit. And think of it as a net. Every hole in the net is an opportunity for organisms to escape. There are 5 pillars of infection control drawn directly from Ask Mid-Grade methodology, provides a practical framework for our discussion. The first pillar, hand hygiene, the cornerstone of all infection prevention. Second pillar, contact precautions and isolation, separating colonized and infected patients from susceptible ones. Pillar 3, active screening cultures, finding hidden carriers before they become sources. And pillar 4, environmental cleaning, eliminating the environmental reservoir. And pillar 5, antimicrobial stewardship, reducing the selective pressure that drives resistance. Each pillar is necessary. None is sufficient alone. So let us examine each in turn. The mechanism, the first one, pillar 1, is hand hygiene. The mechanism is straightforward and powerful. Alcohol-based hand rubs physically reduce Acinetobacter baumannii and other gram-negative counts by 98% from experimentally contaminated hands. And this is among the most effective single interventions available for us. But there are strict prohibitions that must be accompany this. Artificial fingernails are directly linked to outbreaks of ESBL, Klebsiella pneumonia, Pseudomonas aeruginosa in neonatal intensive care units, and they must be banned in clinical areas. Rings triple Enterobacteriaceae carriage risk. The evidence base supports strong recommendations with moderate evidence for targeted hand hygiene. Education specifically focused on ESBL producing Enterobacteriaceae, MDR Acinetobacter, and MDR Pseudomonas aeruginosa. Education alone is insufficient. It must be paired with infrastructure, alcohol hand ramps available at every point of care, and regular monitoring of compliance. Healthcare facilities must implement hand hygiene best practices according to the established WHO guidelines. Three requirements stand out. First, the availability of appropriate infrastructure, alcohol-based hand rubs at the point of care, not just at the entrance to the ward, every bedside, every treatment room, every clean utility room. Second, training that's not a one-time event, but ongoing with specific content targeted to the resistant organisms prevalent in your facility. And the third, regularly monitoring staff compliance, not as a punitive exercise, but as a quality improvement tool, what gets measured gets improved. So this landmark paper from Peter and colleagues published in the Lancet Infectious Disease in 2006 provided one of the clearest demonstrations of how pathogens transfer during patient care. In the image 1, it shows a patient in bed, colonized with microorganisms on their skin and in their immediate environment. Image 2 shows a healthcare worker providing care, and in the process, their hands become contaminated. Image 3, the graph shows microbial colony counts on hands over time, with and without gloves. Ungloved hands accumulate bacteria linearly with the time spent providing care, and gloved hands start lower but still accumulate. And the key insight, even routine care activities, not just invasive procedures, contaminate healthcare worker hands. And bacterial counts on hands increase with every minute of care delivery without hand hygiene. From the same paper, we see the factors that influence whether hand transmission leads to patient infection. These include the characteristics of the microorganism itself, its virulence, and environmental persistence. and the quantity of organisms transferred higher inoculum means higher risk. The patient's underlying diseases, immunocompromised patients are far more vulnerable. The invasive interventions in place, central lines, urinary catheters, ventilators, all provide entry routes. And moisture levels, wet environments favor microbial survival and transfer. And the visual on the right here shows how microorganisms can transfer indirectly from one patient through a healthcare worker to another patient who is distant in the ward. Cross-room transmission is possible and has been documented. And this complexity is why hand hygiene must be rigorous, constant, and supported by the entire system of care. The WHO's 5 moments for hand hygiene provides a practical, memorable framework for when to perform hand hygiene. Moment 1, before touching a patient. Moment 2, before a clean or aseptic or procedure. Moment 3, after body fluid exposure risk. Moment 4, after touching a patient. Moment 5, after touching a patient's surroundings. The technique matters also, as well. Hand rubbing with an alcohol-based formulation should take 20 to 30 seconds. Hand washing with soap and water required when hands are visibly soiled takes 40 to 60 seconds. The specific steps shown in the WHO poster are not arbitrary. They ensure all surfaces of the hands are covered, including the dorsum, interdigital spaces, thumbs, fingertips, and wrists. And you have to train your staff on both when and how they should do the hand hygiene. These are both matters. Contact precautions form the second pillar of infection control. The protocol is clear. Mandatory gowns and gloves upon entry to the room of any patient with a known or suspected MDR pathogens, and removal of PPE and performance of hand hygiene immediately upon exit before touching any surface outside the patient zone. Alert systems, electronic codes in the hospital information system should identify previously colonized patients at the time of any feature admission. This triggers preemptive isolation before laboratory results are available. Precautions should be maintained until confirmed clearance. The practical requirements for contact precautions include 4 key elements. First, ensure appropriate patient placement. This means a single room when available or cohorted with patients carrying the same organism when single rooms are full. Second, use personal protective equipment, PPE, specifically gloves and gowns for all direct contact, not just for invasive procedures, for any contact. Third, limit patient transport and movement within the facility, because every unnecessary trip out of the room is an opportunity for environmental contamination. And the fourth, use disposable or dedicated patient care. Fourth, use disposable or dedicated patient care equipment, shared equipment. Blood pressure cuffs, stethoscopes, thermometers are among the most commonly overlooked vectors of transmission. Here, this is WHO endorsed guide summarizes the correct sequence for donning and doffing PPE for contact and droplet precautions. Donning sequence: perform a hand hygiene, put on gown, put on mask, put on eye protection, and then gloves. Doffing, the removal sequence, is actually more critical because the contaminated PPE can easily transfer organism to previously clean hands or clothing. The sequence: remove gloves first, then gown, then perform hand hygiene, remove eye protection, remove mask, then perform final hand hygiene. This sequence is not arbitrary. Each step is designed to minimize self-contamination, so it must be trained, practiced, and audited. Simply providing the equipment is not enough. The technique of using it safely must be mastered. Patients colonized or infected with MDR pathogens must be physically separated from non-colonized patients. The rationale is simple. Proximity increases transmission risk, and the hospital environment, including the air, surfaces, and equipment in a patient as a reservoir, they act as a reservoir and becomes an extension of the patient as a reservoir. And the preferred method is single room isolation. When this is not available, cohorting, grouping patients carrying the same organism in a dedicated bay or area where with dedicated nursing staff is the recommended alternative. For specific organisms, particularly Acinetobacter baumannii, Calcaneticus complex, and Candidosima iris, an isolation room with an anteroom and specific air management is recommended, reflecting the airborne dispersal potential of these organisms in certain circumstances. One of the most common questions in practice is, when is it safe to remove isolation precautions? The answer is organism specific. It requires follow-up cultures because the duration of MDR pathogen carriage is unpredictable at the individual level. Some patients clear within weeks, others carry organisms for years. The key principle is that we cannot rely on clinical impression alone. Laboratory confirmation of clearance is required, and the specific requirements differ substantially depending on which organisms we are dealing with. And now let me walk through the guidance for each major organisms. For ESBL, producing and MDR enterobacterials, the end of carriage is confirmed with 2 negative culture sets collected on separate days, starting at least 3 months after the last positive culture. For CPE and CRE, MDR Pseudomonas aeruginosa, resistant Acinetobacter, Candidosima iris, these patients are considered MDR positive for 1 year following the last positive culture. After this 1 year period, clearance is confirmed with 2 negative culture sets collected on separate days. And for VRE, because VRE carriage is often long-term, patients are considered positive for 1 year after the last positive culture. Confirmation of clearance requires 5 negative culture sets collected on different days. Also, these are the Dutch guidelines. They are very strict. However, this requirement is reduced to 3 culture sets if the laboratory uses both selective broad enrichment and PCR for detection. And this slide from SHIHA, the Society for Healthcare Epidemiology of America, reveals a critical gap in current practice. For CRE, 99% of hospitals use contact precautions, but only 32% have a formal discontinuation policy. For VRE, 90% use contact precautions, but 61% have a discontinuation policy. For MRSA, 89% use contact precautions, but 75% have discontinuation policy. So we can say that overall half of respondents of C. difficile and 56% as their most problematic pathogen, yet contact precaution duration practice remain highly variable. And this matters for two reasons. Without a clear discontinuation protocol, patients may remain in isolation far longer than necessary, with real consequences for their well-being and their access to rehabilitation and their care quality. Conversely, premature discontinuation risks reseeding the unit, and the evidence-based discontinuation protocols are not just nice to have, they are essential components of a complete IPC program. For MRSA, SHIHA guidance recommends a clear discontinuation policy based on negative screening. Here you can see also for VRE, you can find all these things from here. For C. difficile. For all MDR organisms, several practical requirements govern the timing and size of clearance cultures. Antibiotic timing, if the patient has received antibiotics to which the MDR pathogen is susceptible, the first follow-up culture must wait at least 48 hours after the antibiotics have been discontinued, because antibiotics suppress shedding and can cause false negative results. Sampling size, cultures should generally include rectal swabs or fetches as the primary site, plus relevant clinical sites, wounds, urine, if catheterized, respiratory secretions, if ventilated. For Candidezima auris, specifically, the guideline requires a more extensive sampling set, throat, nose, perineal area. And post-clearance monitoring for all MDR pathogens except ESBL E. coli and group 2 Enterobacterus take one additional follow-up culture set on readmission within the first year after carrier status was determined. Recurrence is possible and must be detected early. Here you can see the summary of the contact precautions and the screening cultures. Candida auris demands special attention because its isolation requirements differ meaningfully from most MDR pathogens. Unlike ESBL, E. coli, and CPE and VRE, which require only a single room with dedicated sanitary facilities, Candidozima auris requires a negative pressure isolation room with an anteroom and specific air management. This reflects documented airborne dispersal of Candidozima auris in healthcare environments. Additionally, healthcare workers must wear a surgical mask when providing direct care for a Candidozima auris patient, again, reflecting the airborne and skin dispersal characteristics of this microorganism. And these enhanced requirements exist because Candidemia auris combines high transmissibility, prolonged environment persistence, and frequent multi-azole resistance into a particularly dangerous package. When testing for clearance of Candidemia auris, the sampling protocol is more extensive than for bacterial MDR pathogens. And 3 additional requirements set Candidemia auris apart from most other MDR pathogens. First, the wait periods for clearance, mandatory admission screening, and the standard MDR precautions still apply. And this is a summary of the Dutch hospital guidelines for screening. Here in this slide, we introduce fundamental tension in MDR management. The demand for isolation rooms constantly exceeds supply. 3 forces are driving increased demand: expanding immune-compromised populations, emerging MDR bacteria, and novel viruses, including SARS-CoV-2, Ebola, the others. Meanwhile, the supply is critically constrained. ECDC data from 2022 and 2023 shows that countries like Greece, Hungary, Romania, and Serbia have fewer than 5% single-bed hospital rooms. France and Sweden, at the other end, have more than 50% of single rooms. The takeaway is sobering, indiscriminate, one-size-fits-all isolation protocols are resource-heavy and geographically unscalable. In this paper, also, we summarized it. A targeted precision model is required, one that allocates our limited isolation capacity to the patients who need it most. From our own research review published in Antimicrobial Stewardship and Healthcare Epidemiology 2025, we propose exactly such an approach. The old model of infection prevention was reactive, one size fits all, and protocol driven. A positive culture triggered isolation and end of decision making. The new model, patient-centered IPC, is personalized and proactive. It incorporates pathogen characteristics, patient risk factors, and clinical genomics and facility data, and nurse-to-patient ratios, room availability, local epidemiology to make risk-stratified decisions. The advantages are compelling: resource efficiency, better adaptability to changing epidemiology, and the potential to leverage machine learning and targeted environmental controls. And this pathogen treatment risk illustrates why different organisms require different responses. And you can see that our risk in this paper, in this review, our risk-based framework for isolation prioritization uses 3 pillars of assessment. Pillar 1, pathogen transmissibility and environmental persistence. Pillar 2, pathogen susceptibility and microbial load. Pillar 3, facility infrastructure and capacity, and these 3 inputs generate an isolation priority hierarchy. And one of the most important and underappreciated concepts in MDR control is the super contaminators. The 1880 rule, derived from research by Lerner and colleagues, shows that just 18% of carriers account for 80% of environmental contamination. The feature of infection prevention is AI augmented decision making, electronic health records, hospital epidemiology data, patient omic profiles, and staff workload and facility data will all feed into a machine learning engine that generates dynamic isolation priority scores, high-risk patients, medium risk, and low-risk patients. High risk isolate immediately, medium risk standard precautions, and low risk safely de-escalate. Pillar 3, active screening cultures are the intelligence gathering of infection control. They reveal the hidden carriers, patients who are colonized but show no clinical signs of infection, who silently seed the environment. So it is important in the control of MDR pathogens, also surveillance. The surveillance operates two levels: surveillance of infections, ongoing clinical and laboratory monitoring to identify carbapenem resistance in clinical samples, and surveillance for asymptomatic colonization. This should be guided by local epidemiology and patient risk assessment, such as prioritizing those with a history of recent hospitalization in the agents. So the fourth pillar is the environmental cleaning, and because every element of the hospital environment can harbor pathogenic microorganisms, and you can see that if there is a hygiene failure, ICU infection increases. And this bar shows the how long major organisms, hospital pathogens survive on the surfaces. Facilities must ensure strict compliance with cleaning protocols in the patient zone, which includes the patient's immediate surroundings and frequently touched surfaces like bed rails and bedside tables, and multimodal strategies are important also in environmental cleaning. Terminal cleaning is the comprehensive disinfection performed after a patient of MDR leaves a room, whether by discharge, transfer, or death. It is very important in the MDR pathogens. Also, you can consider complementary decontamination methods for MDR pathogens as UV or hydrogen peroxide. Assessment of cleanliness is also important. Visual inspection alone is not sufficient. You have to monitor. You can use microbiologic sampling, ATP, and fluorescent markers, and you can see the advantages and disadvantages of these methods in this scheme. And this CDC diaphragm captures the essential logic of why environmental clinical is a central IPC intervention, not a peripheral role. You have to have a bundle strategy for the environment monitoring and audit, also important. And you can see here the scheme that summarize for MDR pathogens control, and also antimicrobial stewardship is the important pillar in the control of MDR. And you can find all the things, important things here in this SMIT guideline. Also, this table shows the difference between the IPC measures in endemic setting and in epidemic setting. It can be differ, and in this also table I summarize all the things for the microorganisms. So let me highlight the three most important insights from the SMIT evidence matrix. First, MDR Acinetobacter baumannii has the most comprehensive, strong recommendations in the endemic setting. It is the only organism where environmental cleaning carries a strong recommendation at baseline. Also, ESBL, Enterobacteriaceae, and the MDR Klebsiella pneumonia received the strongest epidemic setting bundle. Streptococcus, Maltophilia, and Burgdorferi species have very weak direct evidence. So it is, you can see the summarize in this graphic. Implementation was also very important in the facility level, in the national and with the regional and regional stakeholders, and also all the organizations. Our final summary slide brings together the complete estimate framework for controlling MDR gram-negative. I would like to thank all of you for your patience. Thank you so much.
Дуже дякую за вашу цікаву та вичерпну
Thank you very much for very interesting and detailed presentation. And now we are proceeding with the next session, which is a Q&A session. In order to ask a question, dear participants, please write down your question in the chat so that our speaker could answer this question. Let me also remind you that during today and tomorrow, you need to undergo testing. For that, you need to use the keyword of today's lecture, which is antiseptic. So now we are, I can see many questions in the chat already. So the first question is about the following: microbiological monitoring or cleaning quality. What is the scope and how to assess efficiency and cost effectiveness of this approach?
Microbiological sampling is not in routine use for monitoring or environment cleaning. It's you can use only in the outbreaks situation. In the practice, we usually ATP and fluorescent marking are usually used. Microbiological sampling is not in the routine use, it's only in outbreak situation.
Також запитують в чаті обстеження яких безсимптомних
There is another question in the chat.
щодо яких збудників бажано рекомендовано проводити.
The question is, what asymptomatic patients should be screened and for which pathogens?
For asymptomatic patients should be screened because to prevent the transmission and to have the contact precautions for these patients. For MDR pathogens like VRE, in some situation MRSA, but for VRE or Candidezima auris, you have to screen these patients, especially the high-risk patients, prolonged hospitalization or transfer from an outbreak or endemic setting. You can screen for asymptomatic patients for the colonization to prevent cross-transmission from these pathogens, especially if you are not, your institution is not endemic for these pathogens. For example, in the Netherlands, they have a search and destroy policy for MRSA and other MDR pathogens.
Дуже дякую, повністю підтримую, що важливо визначити.
Thank you very much. I fully support what you've said, that we need to identify the target audience. And during colonization screening, we should identify dangerous potential multidrug-resistant strains according to WHO recommendations, carbapenem-resistant organisms such as Klebsiella, Viri, etc. The next question is, how do you calculate isolation rooms in your country for the patients? Are they all single rooms?
Most of them are single rooms. You know that also anteroom, the rooms, isolation rooms with anterooms are only now suggested or recommended for Candidezima auris and carbapenem-resistant Acinetobacter baumannii. But for other MDR pathogens, you can use single rooms. Also, in my country, now we have a very large hospitals with, for example, in my hospital, we have 4,000 beds, and most of them are single or rooms or a room with double bed. So we do not have any problem in this new hospitals. The rooms with anteroom, we only use for Candidezima auris or airborne transmission, also for example, tuberculosis for tuberculosis patients. But single room is enough for MDR, most of the MDR pathogens for isolation.
Дуже дякую за ваше питання і враховуючи
Thank you very much for your answer. And since we are quite short of time, we will answer two last questions and we will finish. The next question is about Candida auris. And the question is, in which departments we should designate such isolation rooms for patients with Candida auris?
If I understand correctly, you are asking in which services Candidezima auris you always need isolation for these pathogens, and in every clinic we are isolating these patients. You have to have a very strict isolation. Am I understand correctly, or I cannot understand the question exactly, but
в яких відділеннях потрібно
I will clarify a little bit. In which departments, in which units, the isolation rooms should be established to isolate patients with Candida auris?
Especially in ICU patients. Also, ICU patients are risky patients, and also in some immunosuppressed patients, because for Candidezima auris there are also risk factors like prolonged antibiotic use or others. But in every unit you can have isolation rooms. For example, in my hospital we have isolation rooms in every unit, single room or with anteroom. But if you have limited capacity, you can have in ICU, maybe it's because they are mostly prevalent in ICU patients.
Дуже дякую за відповідь. Я впевнений, що
Thank you very much for your answer. I'm confident that the patients really meant this question. ICU is the most relevant unit, in my opinion, too. And the last question is, what recommendations can be provided to colonized patients after their discharge? Are there any special recommendations to such patients? Maybe some brochures or leaflets, or just verbal?
Yeah, you can have this kind of brochures, but if these patients are going to their home, and if they do not have any immunosuppressed patients or any other things, any risky patients, it is not very dangerous for their relatives in their home. So only you can say only maybe for basic infection control, like hand hygiene. But sometimes we transfer these patients to the nursing homes. So when we are transferring to these colonized patients to the nursing homes, we make a note in their file about the isolation of these patients also in the nursing homes. Sometimes they are going to a palliative care, but if they are going to their home, it's not very problematic in their home. But if you transfer them to the nursing homes or palliative cares, also you have to inform the facility about the isolation of these patients.
Дуже дякую, що якраз на цьому акцентували увагу.
Thank you very much for stressing this issue, because it's really important, especially if patients are colonized with dangerous strains and if they're transferred to some other unit or some other facility like nursing home, etc., or hospice. It's really important to safeguard their surrounding. Yeah, this was the last question for today, and we're going to finish today's webinar. I would like to remind our participants that the continuation of these webinars is going to happen for sure. And in order not to miss any announcements, please subscribe to the Facebook page of the UPHC. And today's recording will be uploaded to the UPHC YouTube channel. So please get subscribed, and there you can find all the previous webinars, which we would strongly recommend you to watch. It's also about infection control and antibiotic stewardship. Don't forget about testing after you follow the link which you received when you got registered to today's webinar. You can use your own account, and you should undergo the testing by the end of tomorrow. And the keyword is antiseptic. And let me thank once again to our colleagues from ICAP, Columbia University, CDC, US CDC, and the Professor Emine, who made a really great and useful presentation today. Thank you very much. Have a nice day, and thank you for your attention.
Thank you so much for having me.